Respected colleagues and experts online, good evening. I'm Dr. Liu Jian from Peking University People's Hospital, chair of this symposium. It is my great honor to host this event, Sino-Foreign Expert Dialogue, the role of the beta blocker in coronary heart disease treatment strategy, co-hosted by Asian Society of Cardiology and the Beijing Heart Society. First, on behalf of the organizer, I warmly welcome all the colleagues joining us online and extend your sincere thanks to our speaker, Professor Ricardo Fontes Carvalho from the Portugal, and
Hello.
Professor, yes, welcome, and Professor Liu Wei, Zhang Wenduo, and Li Jianqiang from China. Coronary heart disease is a leading cause of cardiovascular death globally. In China, over 10 million people live with CHD, which continually rising morbidity and mortality. Optimizing standardized whole course treatment and improving long-term outcome for CHD patients is the core global of our clinical practice. In CHD pharmacotherapy, beta blocker are cornerstone therapy, validated by decades of evidence-based research. By inhibiting excessive sympathetic activation, they slow heart rate, reduce myocardial oxygen demand, improve myocardial ischemia, and reverse ventricular remodeling. Abundant study confirmed that beta blocker significantly reduced risk of all-cause mortality, recurrent myocardial infarction, and other adverse events in CHD patients. They have long been a class 1 recommended core medication in Chinese and international guidelines, with an unquestionable cornerstone status. Meanwhile, with the advance of precision medicine, a wealth of new evidence on beta blocker has been emerged in recent years, bridging new clinical reflections. How to accurately screen patients with the best benefit and made individualized region for those with multiple comorbidities. What are the difference in the clinical application of beta blocker with the different properties? These key clinical questions are exactly the focus of our discussion today. Today, we have built this platform for Sino-Foreign academic exchange. Next, Professor Ricardo Fontes Carvalho will present the latest international evidence-based advance in beta blocker. Then, Professor Liu Wei will analyze its key application points in CHD treatment, combined with the clinical practice in China. After the presentation, Professor Zhang Wenduo and Li Jianqiang will join the in-depth discussion on clinical hotspots. We hope this dialogue will help us research academic consensus, standardized clinical practice, and ultimately benefit more CHD patients. Thank you again to all of the experts for your sharing and all of colleagues for your participation. I wish the symposium is complete success. Now I declare this symposium officially begin. Thanks. So let me to introduce Dr. Ricardo Fontes Cavallo. He's director head cardiology department of GIA Hospital Center, full professor of cardiovascular science, faculty of medicine, University Portugal, Portugal, founder European Society Cardiology, ESC, Cardiologist of Tomorrow, treasurer, board member, European Society of Cardiovascular Imaging, governor, American College Cardiology ACC, MCS Health Economics, London School of Economics, associate editor, Journal of American College Cardiology, JCC, more than 200 publications, 13 prize and awards. Today's topic is a coronary heart disease and beta blocker update on latest evidence. Welcome, Dr. Ricardo.
Thank you very much. So, good evening to all of you. Here it is still good morning. We are before lunch, but it is really a pleasure to be with you today. Thank you, Professor Liu, for the kind introduction. And it is really a pleasure to be here with you today, especially because of two reasons. Because it is a good opportunity to exchange knowledge, exchange clinical practice, but also it is a fantastic opportunity because, as Professor Liu said, in the last year, we had a lot of new evidence regarding the role of beta blockers in coronary artery disease. And what I will try to do in the next minutes is to summarize all the evidence coming from a lot of new clinical trials. We will go to guidelines, but more importantly, as Professor Liu said, we will try to bring clinical messages so that we can improve our clinical practice in the management of our patients with cardiovascular disease. So the idea here will be not only sharing experiences, but also trying to bring the latest evidence applied to clinical practice, which is something which is, I think, more important to try to bring something to improve the management of our patients with cardiovascular disease. So, as Professor Liu said, we will be discussing the role of beta blockers in coronary artery disease with an update of the latest evidence that came up in the last year. So, in the next minutes, I divided my presentation in three main parts. First, we will discuss some general topics of what is happening regarding the management of cardiovascular disease in general. Then we will go into 5 clinical trials that were published in the last year, what they teach us in terms of scientific evidence. And then at the end, we will bring these conclusions to clinical practice on how these trials can inform and improve our clinical practice when we take care of patients with coronary artery disease. Although beta blockers have several other indications, for instance, heart failure, but also in hypertension, today we will concentrate mainly on coronary artery disease. If you have any questions, at the end we will have time for discussion, and we can go to in the discussion part to data outside the management of coronary artery disease. So before going into very specific details, let me just share with you some of the evolving concepts that are happening nowadays in the management of cardiovascular disease. As you all know, cardiovascular disease is the #1 killer across the world in most of the countries, but we don't have only bad news. I like very much this slide, which was published in the 200 years of the New England Journal of Medicine, which showed us something which is fantastic. We altogether managed in the last years to significantly improve the age-adjusted mortality for cardiovascular disease. So, with a lot of new therapies, a lot of new diagnostic tools, but also with new technologies, but by the way, by improving the organization of care, we were able altogether to improve, to achieve this fantastic result, which is a marked reduction in the age-adjusted mortality for cardiovascular disease. So, as you can see here quite well, across the globe, we have seen in 2 decades a 40% reduction in the age-adjusted mortality for cardiovascular disease. So, there is here a very important message that I would like to deliver, which is we know nowadays that cardiovascular disease is largely a preventable disease, first of all, and then it is a treatable disease. Once you diagnose it well, it is possible to treat well coronary artery disease, and with this, giving more life to the patient, but also improving quality of life to our patients. So, this is my first important message that I would like to address in the beginning of my presentation. Second thing, and now there is here blocked, my slides are blocked now. Um, are you seeing my slides?
Yes,
Yes,
it's very well.
because,
Yeah,
sorry, it is blocked. 1 minute, I will try to
no problem.
go through here. The PowerPoint is blocked, so sorry for this. I don't know what is happening, but I will close and
You
put
have
again.
some video or cartoon in the
Yes, it was a video, but probably this was the reason why it was blocked. 1 minute, I will open again and share again the slides. Sorry for this.
okay.
I'm opening again the PowerPoint. Sorry.
Okay.
It's opening. Okay.
It's a treatable.
Yeah, it was probably the video with that. Okay. Let us get again. PowerPoint. Okay. So, as I was saying, cardiovascular disease is a preventable and treatable disease. Another important thing is a very strong message also, which is what explains this improvement in the management of cardiovascular disease? There are two main reasons. It's not the stents or the ICDs, these kind of fancy things. The most important reasons to improve mortality for cardiovascular disease are things that we all together can deliver to our patients, mainly medical therapy and prevention of cardiovascular risk factors, which is the most important thing, which delivers this improvement in the age-adjusted mortality for cardiovascular disease. And this brings us to a third evolving concept, which is very important. When we take care of patients with coronary artery disease, nowadays we know that there are some pillars of treatment of secondary prevention of coronary artery disease. As you know, antithrombotic therapy, the importance of reduction, aggressive reduction of LDL level. Nowadays, we also know that we need to reduce a little better the blood pressure levels, but also treating obesity and diabetes. And with this, the third concept which is evolving is that we need to individualize the therapy according to the patient needs, because nowadays we have fantastic tools to better understand our heart, each individual patient, and then we as physicians will deliver the therapy according to the patient profile of the patient that we have in front of us. So this is another evolving concept from the importance of reducing and implementing the coronary artery disease treatment to the concept of individualizing therapy. We go to this latest concept, which is we will need therapies that are able to do two things. As we can see here, prolong survival. I showed you how this is possible. It is possible, but also improve quality of life, which is improving the symptoms of our patients with cardiovascular disease, bringing also this concept, which is shared decision making, individualized therapy, so that we can treat better our patients with cardiovascular disease. So I would say these were some general concepts that are evolving in the way on how we deal with patients with cardiovascular disease. In the second part of my presentation, I will now address the role, the new data regarding the role of beta blockers in coronary artery disease management. As you know, this is a hot topic nowadays, and what I will try to bring is what is new regarding the use of beta blockers in coronary artery disease. As Professor Liu said in the beginning, we know that blocking the beta 1 receptor has several advantages in the management of coronary artery disease, from remodeling to reducing the requirements of oxygen to, as you know, improving angina symptoms. But one thing which is key when we discuss the role of beta blockers, and we know that the benefit comes mainly for the blockade of the beta 1 receptor, is understanding that beta blockers is a highly heterogeneous class of drugs. So we should not look at beta blockers as a class effect, as a non-homogeneous class of drugs, because as you can see, there is a high heterogeneity, and we need to use drugs, beta blockers, that have shown to improve symptoms or improve prognosis of patients with coronary artery disease, because there is a lot of variability in the pharmacological profile. As you know, and we will discuss this at the end, for instance, one of the beta blockers that we have, the bisoprolol, has a selective beta 1 blocker effect. It has an anti-ischemic effect by angina relief. One thing which is good for our patients is once daily administration. But by the way, we know now from data published in JAMA quite recently how safe it is even in patients who have respiratory disease, who have, for instance, COPD. Let's go now into all the evidence that came in the last year and try to bring clinical messages. What is fantastic regarding this area is that in only 1 year, there have been 5 clinical trials, as you will see, that try to address the role of beta blockers in coronary artery disease. What is fantastic is I don't know any other disease or any other subject who had 5 clinical trials in the New England Journal of Medicine in such a short time, as we will see in the next minutes. And what we will do is to go into some details of the trials and try to bring clinical messages one by one. So let's start with the story, how it began and how it is going. The first clinical trial, which assessed the role of beta blockers in coronary artery disease, was the REDUCE-MI study. So this is a registry-based randomized clinical trial, which has a limitation. By the way, this is a limitation of all these trials, which is an open label trial. Okay, so this is not a double-blind clinical trial. And in this trial, 5,000 patients who had a previous myocardial infarction with a preserved ejection fraction were randomized to beta blocker versus no beta blocker. One thing which is very important is to look at the inclusion criteria in these trials, and this is also common to all of these trials. These patients were very well treated patients. All of them went to coronary angiography, and almost all of them had complete revascularization. So I will go with this into the end. This is a subset of patients with acute myocardial infarction. And as you know, in this first trial that I showed, the results were neutral. Beta blockers did not significantly improve the prognosis of patients after a myocardial infarction. I'm not going to enter into all the details, but overall, the results were neutral. Don't forget, some limitations of the trial, the open label design, but also another limitation that you can see here. There was, because of the open label nature, there was significant crossover between the two arms, and this has, of course, some limitations in the interpretation of this first trial. Let's go now into the second trial. The second trial is called the ABYSS clinical trial. So same idea in general, but here see a slightly different design. Patients with a previous myocardial infarction, they were taking beta blocker and they were randomized to stop the beta blocker versus continuing the beta blocker. So slightly different, as you can see. And what was observed in this trial was when you interrupted the beta blocker, these patients had a worse prognosis. And there was mainly an increased risk of this endpoint, which was an hospitalization for cardiovascular reason when you interrupted the therapy with beta blocker. By the way, we know now from a sub-analysis from this ABYSS clinical trial assessing patients from this trial who had hypertension. And this sub-analysis shows that when you stop the beta blocker, there is an increase, as you can see on the right, in blood pressure, systolic and diastolic blood pressure, a 10 points increase in heart rate, and these patients interrupting the beta blocker was associated with an increased risk of having a cardiovascular event, which was hospitalization for a cardiovascular reason. So here, a word of caution regarding the interruption of beta blocker after the myocardial infarction. More recently, in the last Congress of the European Society of Cardiology in September this year, so 6 months ago, there was in the same session two clinical trials that were presented with slightly different results that we will address in the next minutes. The first trial is called the Reboot clinical trial. Again, large trial, 8,000 people, randomized, again, open label design, which has some limitations, and patients were randomized to receive beta blocker versus non-beta blocker. As you can see from the patient characteristics, I will address this later, it is a good population, good patients after a myocardial infarction. And as you know, in this trial, the results were neutral. Continuing or taking or not the beta blocker did not significantly change in this trial the prognosis of patients after a myocardial infarction. What was interesting was that in the same session, so 5 minutes after the presentation of this previous trial, a second trial, also conducted in Europe, but this time in Northern Europe, tried to assess more or less the same thing. Patients after myocardial infarction, randomize the patients to beta blocker versus non-beta blocker. As you can see here, the results were different from the first, which was patients taking the beta blocker had a lower risk of cardiovascular events, 50% reduction in the risk of cardiovascular events. So now, how can we interpret all these trials? How can we interpret the clinical message behind these trials? What are the take-home messages from the information that we had from these important clinical trials? Let me try to summarize into some practical messages and to some clinical messages. First, this is an important thing, which is a meta-analysis. These trials included, some of them, patients with an ejection fraction above 40%, and in other trials, it was above 50%. This meta-analysis, which was published recently in Lancet, is very important to show us one thing, which is all patients, if the patient has an ejection fraction between 40 and 50%, there is a very clear benefit of the intake of the beta blocker because, as you can see in this large meta-analysis, these patients had a 25% reduction in the risk of cardiovascular events when they take the beta blocker. So this is information that is clear, that is new, and that came from these clinical trials. Second message, which I think it is very important. I showed this to you in the beginning. These trials included patients, which is a selection of patients after myocardial infarction. Why? You see this very well in the comparison of the results from the trials and with the comparison what is real world evidence. I will show you in a minute. If you compare the rate of events in these clinical trials to what we see in our clinical practice and what we see in the real world, which is registries, we see that the rates of events are much higher in registries compared with these clinical trials, showing us that, okay, these are patients after myocardial infarction, but this is good patients after myocardial infarction. You also see this very well here in this beta amide block. As you can see, 70% of the patients with a myocardial infarction were excluded from the trial because of the inclusion and exclusion criteria. So what is the clinical message here? Is that, okay, in the application of these clinical trials to our clinical practice, don't forget that we are like in the tip of the iceberg. We are only seeing the good patients after myocardial infarction, as you can see here very well in this data. So let us try now to go into clinical messages, trying to bring clinical trials applied to the management of our patients with cardiovascular disease. What I think are the main important messages that come from these important trials. First message, these trials did not assess acute phase. Don't forget that this was patients in the chronic phase. So don't forget that beta blockers should be continued to be used in the acute phase of myocardial infarction, because we know that in the acute phase of myocardial infarction, they improve remodeling, they reduce the risk of arrhythmias, they reduce the risk of events. And as recommended in the guidelines, they should be used and should be introduced in the first 24 hours after a myocardial infarction, as long as there is no contraindication like cardiogenic shock. But most of the patients, of course, will need to take the beta blocker in the acute phase. Second clinical message coming from all these trials. These trials did not assess angina. Don't forget, patients with angina were all excluded from these trials. So beta blockers, as Professor Liu said in the beginning, have an important role in the control of angina, in improving symptoms of angina, and improving quality of life of patients with coronary artery disease. So don't forget, this is also an important message. And as you know, beta blockers is a cornerstone, and they come in the guidelines as first-line therapy to control angina as anti-ischemic drugs to be used in patients with coronary artery disease. Third clinical message coming from all these trials. Don't forget that it is mandatory to take beta blocker in most of our patients after myocardial infarction, because you know that I showed you that most of the patients with an ejection fraction of below 50%, it is very clear the benefit. Don't forget that patients with hypertension will need the beta blocker for the two things, coronary artery disease and to control hypertension. And also don't forget that a lot of these patients do not receive complete revascularization. And of course, we will need to have the beta blocker as a mandatory indication. So this comes to my final take-home message, which is, I think this is a very important sentence. As you know, probably William Osler was the father of what we call nowadays modern medicine. And he usually said one thing which I think is important. He usually said, the good physician is the one who treats the disease, is the one who treats the coronary arteries, the one who treats the ejection fraction, the one who only sees the blood pressure. The greatest physician, and we all together want to be greatest physicians, is the one who takes care of the patient with the disease, which means that we need to individualize therapy, that we will need to adjust the pillars of treatment to our patients with coronary artery disease, and we need to involve the patient in the decision so that we can improve the management of patients with coronary artery disease. Thank you very much for your kind attention, and at the end, for sure, we will have opportunity to have further discussion. Thank you very much.
Thank you very much for Dr. Cavallo gave us a very wonderful lecture focus on the beta blocker treatment in the coronary heart disease. So with the last slide, I think the impression me a lot. The greatest physician is treat the patient with the disease with William Osler. So from this idea, we should treat the patient with the heart disease because beta blocker can reduce the angina pectoris, even with the fully in revascularization, can reduce the myocardial infarction with mortality, and can treat a heart failure, uncontrolled hypertension, and arrhythmia. So even with some study published in recent years, not with the solely positive result with the beta blocker, but we still focus on, we still continue to use the beta blocker to treat patients with the coronary heart disease. Is I think the main part learned from your lecture. Thank you very much, Dr. Cavello from the Portugal. So next speaker is Dr. Liu Wei from Beijing. Dr. Liu Wei is the director of Department of Cardiology, chief physician, professor, and doctoral supervisor of Beijing Jishuitan Hospital. And Dr. Liu's topic of today is the role of beta blocker in the latest treatment strategy for coronary heart disease. And welcome, Dr. Liu.
Thanks for Dr. Liu's invitation and introduction. And thanks for Dr. Carvalho's wonderful lecture.
Thank you.
So, good evening, everyone. Today, I will be discussing the role of beta blockers in the latest treatment strategy for coronary heart disease. Although the beta blockers are one of the oldest drugs classes in cardiology, their role continues to evolve, especially with emerging evidence in recent years. So my talk today will focus on how they work and how we use them clinically and how the new studies are telling us. I will divide the presentation into three main parts. First, we will review the mechanism of a beta blocker and understand how they work physiologically. Second, we will go through their clinical use across different types of coronary heart disease. Finally, we'll look at recent studies that are shaping current practice, particularly in post-myocardial infarction patients. So let us start with the basic mechanism of beta blocker. Beta blockers act by inhibiting beta-energetic receptors, which reduce sympathetic nerve system activity. And this leads to a decrease in heart rate and myocardial contractility. As a result, myocardial oxygen consumption is reduced, and at the same time, the slowing of the heart rate prolongs diastole, which improves coronary perfusion. And clinically, this effect leads to fewer angina episodes and improved exercise tolerance. So fundamentally, beta blockers helps by restoring the balance between the oxygen supply and the demand in the myocardium. And beyond this reducing the heart rate, beta blockers also improve the efficiency of coronary blood flow. And this slide illustrates the cardiovascular disease cascade or starting from the risk factors such as the hypertension and the diabetes, progressing to atherosclerosis, myocardial ischemia, infection, heart failure, and eventually death. And beta blockers play a role at multiple stages of this process. They reduce the ischemia early on, prevent arrhythmias during the acute events, and limit ventricular remodeling in later stage. Because of this, they are not just symptoms relief drugs, but also disease modifying therapies. From a clinical perspective, beta blockers serve the 6 major applications. They are used for a long-term event reduction, for secondary prevention of myocardial infarction, and for heart rate control, and also as the first line therapy for angina, and they also help in blood pressure control and are widely used across different forms of coronary heart disease. And this highlights their broad and essential role in the daily practice. And now, let's come to the clinical guidelines. What's the recommendations and the clinical evidence for the use of beta blockers in different types of CGD patients? So first, the CGD spectrum, one of the strengths of the beta blockers is that they can apply it across the entire spectrum of the coronary heart disease. And this including acute coronary syndrome, chronic coronary syndrome, microvascular angina, and post-revascular resistance states, and ischemic cardiomyopathy. And this wide applicability reflects the central role of sympathetic activation in cardiovascular disease. So let's have a look of the early use in ACS. In acute coronary syndrome, because the sympathetic activity is significantly increased, it leads to higher heart rate, increased oxygen demand, and a higher risk of arrhythmias. And the beta blockers can contradict this effect. And therefore, a lot of guidelines, such as the 2023 ESC guidelines for the management of ACS, and 2023, the Asian Pacific consensus, the role of beta blockers in cardiovascular disease, and Asia Pacific consensus based on diaphragm method investigation. It's mentioned in the absence of heart failure, no cardiac output, cardiogenic shock, and other contraindications, beta blockers should be administered within the first hour, 24 hours of STEMI and the non-STEMI. And also mentioned in the most recent 2025 ACC guidelines, it's mentioned that in patients with ACS without contraindications, less than 20 hours initiation of oral beta blocker therapy is recommended to reduce risk of infection and ventricular arrhythmias. So early treatment is important because it reduces the risk of infection and arrhythmias. In addition, bisoprolol, a third generation of beta blocker, is one of the most commonly used beta blockers in real-world settings for both ACS and stable coronary heart disease patients. So the country indications of beta blockers are not suitable for all the patients. They should be avoided in a patient with a cardiogenic shock and acute coronary syndrome, severe bradycardia, and advanced atrial ventricular block and severe asthma. And we can see that from the first diagnosis of admission to 24 hours until 2 to 3 days and 1 to 2 weeks, the beta blockers is recommended. And the dosage adjustment should be aimed for the target dose with a target rate of 55 to 60 beats per minute. And the beta blocker can be used for ST segment elevation myocardial infarction and the non-ST elevation acute coronary syndrome. Clinical studies has showed that early use of beta blockers in ACS patients reduce major adverse cardiovascular events, as well as the risk of heart failure and cardiogenic shock. And these findings are consistent with guideline recommendations and support early initiation in appropriate patients. And in the chronic coronary syndrome, beta blockers are considered first-line therapy for angina and supported by the domestic and international guidelines, such as 2024 US guidelines and 2024 Chinese guidelines. And for those guidelines, it's indicated that for most of patients with CCS, initial beta blocker and all calcium channel blockers are recommended for heart rate and symptoms control. So the TIP study demonstrates that the beta blocker are significantly reduce the total ischemic burden. Patients treated with bisoprolol had a substantial reduction in both the frequency and duration of ischemic episodes. And this provides strong evidence for anti-ischemic effectiveness. And the TIP study, so for 1 year follow-up, has also significantly reduced the cardiovascular event rate and improved prognosis. And this is a 14 years real-world study in the UK. It's confirmed the long-term efficacy of beta blockers in patients with angina. From the study shows that the bisoprolol is associated with better long-term outcomes, significantly linked to lower mortality and reduce the risk of cardiovascular events. We can see those numbers. It's reduced the occurrence of arrhythmia more than 40% and reduced of the angina more than 42% and reduced the myocardial infarction by 55%. Bisoprolol is a highly selective beta-1 receptor blocker with fewer adverse effects on organs such as lungs, and it also demonstrates higher medication adherence and a lower discontinuation rate, contributing to an explanation of why the long-term prognosis is better in the bisoprolol group. And also for patients with ischemic heart disease and heart failure, treatment of beta blocker significantly reduced the 30 days risk of MACE by 22% and all-cause mortality by 20%. And the beta blockers also significantly reduce the risk of atrial fibrillation post-operatively by 33% compared to patients who did not use the beta blocker. And also, beta blocker reduced the long-term all-cause mortality by 38% during 48 months follow-up period. And This impact of beta blockers on all-cause mortality was particularly significant during the first 12 months. In microvascular angina, the problem lies in the small coronary vessel rather than the large arteries. Beta blocker helps by improving endothelial function and reducing heart rate, making them a first-line treatment in this condition. And it's recommended to use target doses as the titration goal for beta blockers. And beta blockers also improve the endothelial function and alleviate symptoms in patients with mild microvascular angina. And also it can improve the exercise-related parameters following beta blocker therapy. This indicates enhanced myocardial oxygen consumption and reduced myocardial ischemia, thereby improving angina symptoms. We can see the CCF angina classification improved by one or more categories in 70% of the patients. And for asymptomatic ischemia, even in patients without symptoms, beta blockers can improve the cardiac function and reduce ischemic changes seen on ECG. And this suggests a role in managing the subclinical disease as well. So let's talk about the final part, the integration of the heart research topics related to beta blockers. The first study is the beta AMI studies. Shows patients with the myocardial infarction and with preserved ejection fraction, beta blockers still reduce mortality and major cardiac events. And this may challenging the previous belief that their benefits is limited to the patient with reduced ejection fraction. And even the secondary endpoint shows that long-term beta blocker therapy was also associated with low risks of all-cause mortality, myocardial infarction, heart failure, and malignant ventricular arrhythmias. And this is a recent meta-analysis confirms that beta blockers are beneficial in patients with mild or reduced ejection fraction, reducing the risk of death and myocardial infarction and heart failure. And from the primary endpoint and secondary endpoint. And from this base study, it shows what happens when beta blockers are stopped. It found that discontinuation leads to an increase in heart rate and is associated with the worse outcome. And this suggests that continual therapy is very important. And consistently, the 25 very specified subgroup analysis of the base study shows that interruption of beta blockers increased risk of primary endpoint, particularly among patients with hypertension. So let's come to our conclusion. First, beta blockers remains a cornerstone in the management of coronary heart disease. They reduce the myocardial oxygen demand, improving symptoms, and lower the risk of major cardiovascular event and death. And the recent evidence suggests continued use is especially beneficial in patients with preserved ejection fraction, and discontinuation may be helpful. And overall, beta blockers continue to play a central role in modern cardiovascular care. And this concludes my talk. Thanks for listening.
Thank you for Dr. Liu Wei's wonderful lecture. From his lecture, we also learn a lot from the beta blocker, the usage in like a myocardial infarction, a acute coronary syndrome, and also have and hypertension and arrhythmia. So from his lecture, he shows some very interesting hot topics, especially discussing some new evidence about beta blocker. So it's quite similar with Dr. Ricardo previous lecture. So Dr. Ricardo, do you have some comments on Dr. Liu Wei's lecture?
Well, I think in general we are in agreement, which is okay. So we've seen the mechanistical benefits of the beta blocker. As he said, we went to several scientific evidence that is new. What is interesting is that, okay, we understood from all this information that what we are doing well regarding the management of coronary artery disease. So I think it was also a good complement of my data showing the benefits of this therapy in patients with coronary artery disease. We didn't went to the discussion about the role of these patients, for instance, in heart failure with reduced ejection fraction, because there are other indications for the use of beta blockers, but later we can further go to this discussion. But I liked very much this presentation because it was a good complement to the data that I discussed before.
Thank you. Also, from the schedule, we have Dr. Li Jianqiang to join us with the in-depth discussion with two speakers' presentation. So, Dr. Li, I think you are online. Li Jianqiang is a professor and the chief physician and master supervisor, and also have many titles in the many society and many in the China, also in the international. So, Dr. Li, do you have any comments with the two speakers lecture?
Well, I'd just like to thank all the speakers for your outstanding presentations. And I totally agree with professors because over the past 2 years, there were a few very large clinical trials really evaluating the role of beta blockers in patients with coronary heart disease. And so I think the use of beta blockers has been the cornerstone treatment of many cardiovascular diseases. And compared with other beta blockers, as Professor Ricardo mentioned in your slides, bisoprolol has better selectivity, so which ensures its very good efficacy and safety in the long-term use, and especially in the elderly patients, because those patients tend to have some respiratory problems. So when we use the beta blockers in those patients, we don't worry about the side effects of the drug. And there's no question the bisoprolol can better control the heart rates and also reduce the occurrence of angina, thereby improving exercise tolerance. And in terms of the prognosis, I think there's tons of evidence supporting the use of beta blockers in patients with heart failure to reduce the mortality. So the value of beta blockers cannot be questioned, especially in selected patients. So that's my general view on the use of beta blockers. Professor, do we go through all those questions?
Thank you very much. I think we have the panel discussion. We have three topics. Dr. Li has also to share his ideas about this question. But I also want to Dr. Ricardo to share your opinion about these three questions.
Okay, thank you. So I think in my presentation, I addressed this in my final part of the presentation. So I will try to bring again and to summarize into a bit more detail. So regarding the first question that we have here, regarding the long-term management, how do you view the value of bisoprolol in heart rate control, symptom improvement, and long-term prognostic management? As I told you, and I think this is clear from the two presentations, bisoprolol is a very good drug to control heart rate. As you know, and it has been clear from the presentation from Dr. Liu, from Dr. Wei, which was we need in these patients a heart rate of around 60, 55 to 60 beats per minute should be the ideal. And we also focus the role of beta blocker and bisoprolol in terms of angina control, in controlling symptoms of angina. A lot of studies showing these benefits. So I think it was clear from my presentation what is nowadays the role of the beta blockers. How we interpret the evidence, which kind of patients we will need to take. As I said, it is very clear the kind of patient. So all patients who have angina will need lifelong therapy with a beta blocker. Patients who don't have complete revascularization, no doubt, beta blocker is important to control ischemia. Don't forget all patients with an ejection fraction below 50%. This was clear from the meta-analysis that I showed that it has a prognostic benefit clear in this kind of patients. Patients with hypertension who have coronary artery disease, patients who have any kind of arrhythmias, it is very clear from this data that we will need the beta blocker as lifelong therapy. Let me just add one other thing going to Dr. Lee comment. He focused the role of respiratory symptoms and COPD. One thing which is clear nowadays is that if you use a beta blocker who is cardioselective, like bisoprolol, we don't have an impact in respiratory symptoms. I did not have time to show you this, but if you go to JAMA last year, it was published a randomized trial who tested the role of bisoprolol in patients with COPD and at least 2 exacerbations. So severe patients with COPD. And one thing which is clear is the safety of using a drug like bisoprolol, even in these severe patients with COPD and frequent exacerbations. So we are nowadays reassured regarding the role of a beta-1 selective beta blocker like bisoprolol, even in these patients with COPD. So I think guidelines will say more or less the same thing that I showed you before. And I think we have nowadays, with all these trials, more clinical information, although I confess, I didn't change too much my clinical practice compared with what I did before. With this new data, I did not change much my clinical practice. So I use beta blocker in most of my patients with coronary artery disease.
To Dr. Ricardo, my question for you, what kind of situation you will not use beta blocker even in some period?
Good. This is a very good question. So sometimes, and me and you for sure, in your clinical practice, had patients with a previous myocardial infarction where sometimes we forced the beta blocker despite some side effects. For instance, patients had a previous myocardial infarction, and although the patient had a low heart rate or sometimes it felt a bit tired, we pushed sometimes a bit too much the beta blocker. So I would say that if a patient has a preserved ejection fraction, does not have an indication, and has side effects of the beta blocker or have a heart rate below 50, in sometimes individualizing the therapy, remember what I said, the importance of individualizing therapies to our patients. Sometimes I think with this data, if the ejection fraction is above 50% and the patient does not have residual ischemia, we can interrupt the beta blocker in this kind of patients.
Thank you very much. Dr. Liu Wei, can you to share more your opinion on these three questions?
Thank you for Dr. Liu. I think for the selective use of bisoprolol in patients with cardiovascular disease, especially for the patient with MI, is beneficial for patients with the preserved heart function and low ejection fraction heart failure patient. And this has been shown from the guidelines and also from the studies. But recently, we know that the recent trial from ACC, it shows that the bisoprolol may not be so beneficial in patients with a preserved heart failure patient post MI. So I want to get the opinion from Dr. Ricardo about this trial. But this trial shows that the patient who stopped their beta blockers post myocardial infarction, their heart rate is also increased. Uh, mm, how can we explain the result of the increased heart rate, the outcomes of the increased heart rate to the myocardial infarction? So how could you explain the result from the recent ACC trial?
Well, again, trials, we don't have explanation for everything that happens in trials. So for sure, there is an increase in heart rate. And by the way, there is another trial. I did not present this because it was published only last week in the New England. Also, it is about interruption of the beta blocker therapy. What I would say is, okay, if you interrupt the beta blocker, you will have an increase in the heart rate. This is obvious. You will have an increase in the blood pressure. I showed you in the ABIS clinical trial, but it was also shown in the trial that was published last week that we didn't present here today. The question is, as you say, what is the impact that this can have in the risk of cardiovascular events? Again, I think this is an important message. Don't forget that in all these trials that were published, this is a highly selected population. Again, these are the good patients after a myocardial infarction, which usually have by themselves a very low rate of events. So sometimes we don't have statistical power to show or to see increased risk of events because these patients usually, if they are well treated, and in these clinical trials, they were receiving more than 90% had the pillars of treatment of coronary artery disease. In very well treated patients, sometimes you don't see small differences in rates of events. So I think this is the take-home message that I take from these trials also. I don't know if I addressed your question, if it was what you wanted.
Yes. I think yes. That is my question about. So from your explanation, maybe the rate, the major cardiac event rate for those patients who are stable are very low, so they don't come to the statistical significant level. And also, I believe that with the interruption of the beta blockers, the increased heart rate and the increased blood pressure can lead the future cardiovascular events. So I also suggested for patients who can tolerate bisoprolol and has a baseline higher blood pressure and also higher heart rate, I recommend to use beta blocker even for patients with preserved ejection fraction heart failure post myocardial infarction. And this is also, I think, also my suggestions. Thank you very much.
Thank
I
you.
agree with what we just said, which is individualized therapy, which means we, as physicians, we will need to apply scientific evidence to the patient that is in front of us, and we will take in our decision considering scientific evidence, but the patient who is in front of us. So there is no rule to fit all patients. We will need to individualize therapy to each patient. I agree.
Yes, and since we have come to this conclusion, and what is the future study will about? Do you have any idea of the future study?
Well, I would like to see a study with all comers, which is instead of having very selected populations of patients after myocardial infarction, having the usual practice of myocardial infarction, including patients who did not receive complete revascularization, patients who were not submitted to all the state-of-the-art treatment, because this is what we see in our clinical practice.
Yes, I agree with you. Maybe those clinical trials are very selective, but in a real practice, we have a variety of the patients. Um, and I think in certain subgroup of the patient, the beta blockers may not be suitable, but larger subgroup patients post myocardial infarction, especially for patients with the event of acute coronary syndrome, and even patient with chronic coronary syndrome, the patient will be fit for beta blocker use.
Agree.
Professor Caudle, I do have a question I really want to ask you. I don't know what you see the difference between the smart decision, which was just presented last week, maybe 2 weeks ago at ECC, and the results of ABIS. Because those two trials, they were looking at the patients after using the beta blocker for a few months or maybe 1 year, but they got very different results. So now I was wondering, what is the best duration of beta blocker use after acute myocardial infarction? Because from the smart decision, they told us after 1 year use of beta blocker, if the patient's EF value is over 40% and there's no other indications of beta blockers, we can stop beta blockers. From ABIS, if you cannot stop the beta blockers too early, at least not less than 1 year, right? If you start too early, maybe the cardiovascular events will be increased. So I just want to know your thought on these two trials.
Yeah. So thanks for bringing this question, which is a very important question. So I will summarize to the audience very briefly what we are talking about. So there are two trials who assess the discontinuation of beta blocker. One I presented, which was the ABIS clinical trial, and the other was published last week in the New England, which is the SMART decision. What is the difference between the two? Was the time until the interruption. If you go to the average, all of them interrupted the beta blocker more than 1 year after the myocardial infarction. Although by protocol in the ABIS, you will need after 6 months, while in the other trial, it was more stabilized patients. So I think on average was patients who had a myocardial infarction 4 years ago on average. So this brings us into an interesting discussion, which is the results in the ABIS clinical trial, where we saw an increase in cardiovascular events, was because this trial had a protocol for an earlier interruption of beta blocker, or what was this the reason of the difference between the two trials, or something else? I think we will not reach to a final conclusion. What I think is probably in this trial that was Smart Decision, which was published recently, these patients were not only very well treated, as if you go to the control of cardiovascular risk factors, these were really optimized medical therapy, but it was patients who had 4 years after, on average, 4 years after a myocardial infarction. So these were very stabilized patients. So the question is, how long should you do the beta blocker after a myocardial infarction? I would go for what we said before. Knowing all this data, at the end, we will need to individualize the therapy because, a lot of these patients had other comorbidities beyond coronary artery disease. So this brings us to my final slide, which was, remember, the good physician is the one who treats the patient with the disease, which means that at the end, we will need to take in consideration also how long the patient is stable with the therapy when we decide or not to continue or interrupt the beta blocker after myocardial infarction. So probably one of the explanations why the results of the ABYSS was slightly different from the Smart Decision, at the end we will never know, although in ABYSS patients interrupted slightly earlier than in the Smart Decision clinical trial.
Okay, so question, I do want to ask you, what do you see the upcoming guideline? Do you think the guideline would be updated based on the current trials, or the guideline won't have any changes until we have more evidence time?
Good question. I would say one thing, which is this data, especially the meta-analysis, has an important information. As you know, until now, we didn't have too many trials assessing the role of beta blockers in patients with an ejection fraction between 40 and 50%. Why? Because, for instance, heart failure trials, they tested beta blockers in patients with an ejection fraction below 40%. So in patients with 40 to 50%, as you know, the guidelines said may be considered. What these data show us, and this meta-analysis show us, is an upgrade probably in the recommendation in these patients, which is if the patient has an ejection fraction between 40 and 50%, nowadays we have more evidence supporting the importance of beta blocker to improve the prognosis. So I think this will be a change in the guidelines. Then the guidelines will probably say that if the patient has an ejection fraction above 40% and does not have any other comorbidity, individualized therapy according to the patient that you have in front of you. So I think this will be the changes that will happen in the future in the guidelines.
Okay, thank you.
Thank you. Thank you, Sir Professor, deliver your wonderful and also very important ideas about the beta blocker use in the cardiovascular disease. And so I think we come to the conclusion of this symposium in this evening. In the Portugal is in the midday. So I think Dr. Carvalho gave us a very wonderful lecture, have the update concept with the beta blocker use in the coronary heart disease patient, also in the cardiovascular disease patient, especially in myocardial infarction, like uncontrolled hypertension, arrhythmia, and even with heart failure. So from his lecture, I think the most important part we should know is he several times focused on the individual patient treatment is very important. Individual means the different patient mobility and also their situation and their history, medical history, and also individual with their disease condition. In my kind of faction, with ACS or CCS, the patient with the revascularization, also about a left ventricular injection, what was the percentage? And also the individual is about the dosage of the beta blocker usage and the long-term effects, and the patient's heart rate, the patient's blood pressure, all these condition is very important for the usage, the benefit for the beta blocker. And Dr. Liu Wei shared his great idea about the beta blocker usage in Chinese patient. So I think even from China or to the foreign country patient, I think we share the same knowledge, same role in treat patient in our daily practice. And also Dr. Li Jianqiang to join very wonderful, also gave us his ideas about different result of several trials published in recent years. I think this result conclusion sometimes confuse us in some aspect. But I think in today, we should come to some degree of the conclusion and agreement that we should use beta blocker, like a Bezalor, in our cardiovascular disease patient to reduce heart rate, control the blood pressure, to anti-angina pectoris, to have a long-term result, the benefit for the patient. But we should very cautiously to select the good candidate patient, and also very carefully to observe patient heart rate, blood pressure, and also their reaction to the treatment. And I think the guideline is not a rule, but guideline is come from the study, come from the RCT, come from the meta-analysis. We should follow the study, and we should focus on to see what happened in the future about guideline changes. But I think we should consist use beta blocker in the proper patient in our proper study. So thank you very much for all the experts, all the colleagues to join today's lecture. Especially we thanks for the Dr. Cavallo from the European a long way online discuss with us in a very interesting topic. So we wish you have a good lunch after the symposium. Also, thank you, Dr. Liu Wei. After you're driving your electro car and arrive your house, still to share us your wonderful idea about Chinese people usage of the blocker. Dr. Li Jianqiang from the Harbin is a long way from Beijing, also a long way from the European. So we are looking forward for the next symposium. Thank you very much again. To safe and goodbye. Thank you.
Bye bye. Bye bye.
Thank you. Goodbye.
Thank you.
Bye bye.
Thank you. Thank you. Bye bye.